Hello everyone, my name is Dr. Parissis, and today I'm lucky enough to have Dr. Bloxham with me. We are hoping to discuss Verteporfin, the compound that has shown a lot of benefits to scar appearance in a number of studies so far. So very excited to jump into this topic again with Dr. Bloxham. I know he posted a video recently on his channel. If you haven't checked it out, I'll link it in the description, so you do need to check that out. It was a very interesting observation that he made, so I do encourage you to do so. And today what I thought I'd do is, ever since I posted that video of us talking, and ever since Dr. Bloxham has put up his own videos, we get a lot of questions on Verteporfin. I get a lot of emails on it, and I know, Dr. Bloxham, I'm sure you have got so many since posting those videos. So I thought it would be a good idea to ask Dr. Bloxham, who is, of course, running the study, a few of these questions, and a few that jumped out to me. So I hope you're okay with that today, Dr. Bloxham.
Sounds good.
Perfect. All right. So let's jump in with the first question that I thought would be good to ask you. So this question goes, how does Dr. Bloxham believe the use of staples will affect scarring? And does he believe that scarring might be better with other closure techniques, for example, suturing?
Yeah, so typically stapling, especially obviously external stapling, is the way I prefer to close. I've done both many times. Just in traditional FUT procedures. I've stitched many times. I've stapled many times. I personally feel that stapling, regardless of adding any sort of adjuncts like verteporfin, I personally feel stapling externally gives a better wound healing process, a better cosmesis. Sometimes I will use deep dissolving sutures in certain patients, but really on the surface, I like staples. The reason why I like staples, just really quickly, the staples they have a few advantages over sutures, in my opinion, and you can do well with both. Some doctors do beautifully with suturing, others do beautifully with staples, so it's not like there's a right or wrong answer. But what I like about the staples above the sutures, with sutures, when you're doing like a long running stitch in an FUT procedure, you have a lot of big, what we call bites. So in order to, close an FUT defect, you have to take a needle and take a really big bite, wrap it all the way around the other side, take another big bite, and continue that. Then you pull it tight. And with the effect that you get, it's almost like if you took some dental floss and wrapped it around your arm and squeezed it. And that squeezing of the blood vessels as well. So sometimes you can get worse shock loss, you can get permanent shock loss, you can get damage to the underlying vasculature, and that can be harmful. Another thing is that these sutures allow for a little bit more movement in the post-op, which does provide more comfort for patients, but it can also increase the sort of width, I suppose, of the scar. But it can also lead to vertical scarring. Like if the sutures are in like this and your incision is here, when that skin is moving like that, you can actually get vertical scarring. It's like a train track effect or like a baseball stitch effect that I'm sure you've seen. So that's why I typically, for those reasons, prefer staples above sutures. The reason why I use staples specifically in this trial, and I did discuss it with a few other doctors, and if you look at some of the initial studies, the lab studies that were done with verteporfin, they did stitch. The reason I use staples was mainly in this instance, not only do I prefer them in general, but also it was for speed of the closure, because I wanted to minimize the exposure of the verteporfin to the light. When I was closing up these areas, I just verteporfin to be in its inactive form, and it's light activated. So if enough light hits it, it's going to activate it, and it could theoretically not do as good of a job with the wound healing. So because of the way I injected it, because I basically excised the piece and then I injected directly into the part of the tissue in the wound bed where I needed to, there was, the verteporfin was right out there. It's not like I was injecting under the skin with a closed skin surface, or excuse me, above it. So I wanted to close quickly. I wanted to get that stuff in there and just close it and then get a bandage on it as quickly as I can. And the fastest way to close was staples. So do I think that there could be, better ways to close with it? Possibly, but I think the best thing you could do, if in the future these, verteporfin or other YAP inhibitors are used surgically in FUT cases, I would probably let your doctor tell you this is the way I prefer to close, and kind of go with that. It's going to be a combination of the way they're most comfortable closing, what they think is the best closure in the back, plus the verteporfin on top of that.
Brilliant. Thanks for clarifying that. I know the staple versus suture debate has been ongoing for many, many years. So, but yeah,
yeah, it rages on.
yeah, but the research shows they're very comparable. So I totally agree with you as
Yeah.
well from what I've seen. The next question is, what dose of verteporfin did Dr. Bloxham use? And would he consider going higher for better results? Surely more is better.
What I will say is I'm going to remain a little bit mum. I'm going to plead the fifth a little bit when it comes to the specific dosages that I used. There was a lot of calculations, a lot of kind of extrapolation from other tests and papers and stuff that went into it. I'll release all of it at some point, but I have shared it with a few colleagues who are looking to do similar things. But what I will say is this: there is like a dose dependent effect, meaning that more is better. To a certain extent, obviously, you're going to get to the point where more isn't better. However, I've seen some things in the follow-ups in the last month or so, and there's also been a little bit more data, a paper that's probably going to come out soon that indicates that it may not be as simple as more is better. There may be a sweet spot for verteporfin. As to where that is, I think it's going to take a lot of tweaking. I do think there is room to go higher than we're going now. And I probably, if I continue doing this in the future, and I probably will go up a little bit higher. And I think that Dr. Parissis, out of Jordan, he's doing another trial soon. And I believe he's going to use a higher tissue concentration than he had used previously. And I think even a little bit higher than I had used. To my knowledge, I've used the highest tissue concentration in general thus far. And but I think he's even going to go a little bit higher than that. So
next question is a very interesting one, actually. If verteporfin is shown to benefit FUT scars, does Dr. Bloxham believe that it could benefit the appearance of other scars in the body during other procedures, other surgeries, if you like?
The main investigators, a doctor who's both a researcher, a PhD, and an MD, and he's a surgeon. I believe he wants to look at it in cleft palate repairs. I've already seen one procedure that was shared on a I guess it's a private group, where he had a scar on a lip, and he used it, and there seemed to have helped quite a bit, actually. So absolutely, if it works in the scalp, it's going to work. It should theoretically work anywhere on the body. Obviously, the scalp is a little unique, a little different. But yes, I believe that there may come a point where it's utilized, with the initial wound closures in surgeries, and I think they'll definitely, if it sort of pans out the way we hope it does, I think there will be absolute applications for scar revisions, all over the body.
Very, very exciting, isn't it? I mean, to think that your research doesn't only have applications to hair transplant surgery, which of course is a billion-dollar field in itself, but to think that it has applications, to potentially thyroidectomy scars or appendicectomy scars or tummy tuck scars. I mean, that is huge.
Mostly too, they're kind of outlining the burden that scarring plays psychologically on patients, and also the burden, the cost that it basically the cost that's put upon the healthcare system because of it. Because there are people that truly have disabilities because of scarring. There are people that truly have like chronic pain, contractures, things like that from scarring. So if a medication like this could help and things like that, that would be huge. And also, one of the first areas, to my knowledge, where verteporfin started to maybe show some promise in scarring, was actually like visceral, like organ scarring. They looked at it in pulmonary fibrosis, and they also looked at it in like fibrotic processes in the liver as well. So it could have even applications there. It's definitely a lot of promise for sure.
100%. The next question is actually in reference to your previous video, your second update on verteporfin. So from Dr. Bloxham's recent update, the question says, did he do anything different to patient 3? And I think this question is being asked because just to explain to the viewers who haven't seen the video, Dr. Bloxham's study involves 3 patients, and he injected verteporfin in all 3 patients after FUT, but he left areas that were not injected with verteporfin and areas that were, and obviously we're going to compare those, the appearance of those after a period of time. But in his second update video, what's interesting is that patient 1 and patient 2 had a little bit, what seemed to be a little bit of a better response to verteporfin than patient 3. So I think what this person is asking is, did you do anything different with patient 3? Why do you think that the response to verteporfin wasn't quite what it was with patient 1 and patient 2?
So I think there are potentially two variables that could be coming into play with that patient specifically. Variable number one is this patient is the only one thus far where we weren't removing old scar tissue, like we weren't theoretically revising scar tissue. So there may be some difference when you're, removing virgin tissue. That could be playing a role. And I'm not even that it means that it won't end up the same in the end, but it may just take longer, maybe slower. The other potential variable with that patient is I did use the lowest dose that I used the entire day on him. And I used that dose on the other patients as well, but the other patients I used 2 higher doses, but that patient was the lowest dose. So that was some of the evidence that was leading me to believe that there is a dose-dependent aspect to it. Now, as time's going on, I'm not as convinced with that. And I'm actually going to put an update video up pretty soon, so you guys will see that as well. But those could be the two variables. It could be that is a virgin patient, could be the dose was lower, or it could just be that he heals, differently. Who knows? I think it's reasonable to believe that there could be a variable response just in people. Everyone scars differently, everyone heals differently. People respond to medications differently. So maybe some people will respond really well to these medications like verteporfin, maybe others won't. But also everyone heals in a different time frame. It's like the same thing with growth of a transplant. Some patients by 6 months, they look fantastic. It's, video up on YouTube, everything's great. They have that pencil thin scar. Other times you see people at 6 months, they're still really pink. It's kind of just sprouting a little bit. The scar isn't where we want it to be. And that's because everybody heals and matures and their tissue kind of remodels differently. So it could be that he's just a slower, different healer compared to the others. We'll see.
Yeah, makes perfect sense. The next question is also an interesting one. This must have come from a person with a medical background, because they've asked, couldn't verteporfin be absorbed or taken away, washed away, I guess, by the lymphatic system, and therefore need to be injected again at a later date? So I think they mean that, after injecting once, surely, soon after you've injected that, it's kind of just washed away by the blood system, just kind of washed away, and therefore is not really necessarily going to have an effect on the scarring. And so do you need to, or are you considering re-injecting in the future again?
So initially, when I was first introduced to this medication, I thought the exact same thing. It was, presented to me. I was reading up about it, and I'm like, well, again, no one's going to want to come in every month or whatever to have their donor area re-injected. Then I really started to hone in and do some research. And theoretically, you should only need to do it the one time. The way that it's supposed to work in these specific skin cells, these fibroblasts that are going to basically secrete the scar tissue, is those guys are going to be either turned on or turned off, like right when the wound healing process begins. So as soon as they're signaled like, hey, there's a wound here, we got to take care of it. It should be, theoretically, if you get that verteporfin in there at the right time and you genetically switch these guys off, that should be it. You shouldn't need to continually touch it up. Now, obviously, this person's correct that there is going to be washout of it. I was getting washout even as I was injecting it. Patients that are bleeding a little bit more, you inject it and you do see some that kind of leaks out of the wound, basically. In order to counter that, I really didn't use a lot of fluid. There also may be, I've discussed with another doctor using, I didn't really use a lot of epinephrine, adrenaline, basically, when I was, which I usually do in the donor area, to help with bleeding and to also help the medication stay in place and last longer. Because if you inject adrenaline or epinephrine in with numbing medication, it clamps down on blood vessels, and so it doesn't allow the blood vessels to wash away the medication, and the medication lasts longer. So I didn't want to use a lot of that with the verteporfin, because I just didn't want to add another variable. But you could sort of slow that process by doing that. You could slow the process of dilution and wash out by using it. But eventually, yes, the body is obviously going to wash this away. And it will, this person's correct, it will drain into the lymphatic channels in the neck. And that's sort of the sewer system of the body, if you will, or the bloodstream, if you will. But theoretically, if we get it in there soon enough and enough of it gets to these fibroblasts and shuts them off, you shouldn't have to, touch it up like that. Having said that, I think there are some people that are going to try that are going to try touching it up every once in a while. If there was utility in that, then I would. But the theory is, as far as it's been researched now, is that you inject it once and you're good. Theoretically, you should only need to inject it once, kind of turn those cells that are going to secrete the scar tissue off, and then you should be good.
Thanks for clarifying that. So the last question, actually, well, the second last question actually comes from me. So I'm not going to make you, Dr. Bloxham, I'm not going to make you give us any spoilers about your next video. But what I will do is ask you, I know last time you told us that you made an interesting observation before you released that second video on Verteporfin. Have you made any other interesting observations? You don't need to say what they are, but have you at least made any other observations?
Yeah, so I continued to see some interesting things. I'm hoping to get that video up today. By the way, I have, it's going to be a video on 2 antigens from the patients. Once that video is up, we'll be up to date. You guys will have all the data that I do. And from that point on, we're going to be at 4 months pretty soon. Just as soon as I get new stuff, I'll put it out as quickly as I can. But I have continued to see some interesting things. I've definitely continued to, I've seen a continuation of some of the observations I made before. And I still say that it definitely seems like, it's the 2 things that I've said about it before is it's clearly it's doing something, and the areas are healing differently. There's no question about that. I've also made some observations. It's funny, in that last video I mentioned, I think this is going to be a little bit of a roller coaster. I think at some points we're going to be like, oh my God, this is incredible. Look what it's doing. And then other points would be like, oh, I don't know, that's not that impressive. And I have seen a little bit of that in this last video. I've had some, I've had a few times, look at that, that's incredible. And I see another else, and it's, kind of up and down. So that'll be a bit of a roller coaster. But yeah, I've definitely seen it, at least, a continuation of what I observed before, that there seems to be something, going on there. So I do think it is working on human tissue, or is doing something to human tissue.
Perfect. Thanks for answering all my questions and all of everyone else's questions as well. So yeah, so I'll end the video here. Once again, I'm Dr. Parissis. I've had the opportunity to speak to Dr. Bloxham today from New York. I hope you guys enjoyed the video, learned a thing or two more about Verteporfin, and I hope you're just as excited as I am about this compound. So stay tuned for more videos on this, and stay tuned for Dr. Bloxham's video as well on his channel. All right, everyone. Thanks very much.